Okay, physical exam. Any remaining questions about the history? Where I zoom on. Okay, physical exam, not hard to meet these requirements at all. We have the same terms up here: expanded, problem focused, detailed, comprehensive, at the different levels, but the content obviously is going to be different. So on a level 3, this is a pretty straightforward physical exam. Expanded problem focused means that it's one more organ than a problem focused. So problem focused is, very circumscribed problem, and that's all I'm interested in is that little thing right there. That's problem focused. Expanded problem focused means I'm going to be looking at a little more than just the one organ. So an ankle sprain is going to be like a little bit of neurologic and musculoskeletal, and that's about all we're really worried about. So no need to examine much more than that, right? A little above and below in the trauma, and the content would be a simple description of the area of the complaint and a limited number of additional organs. So one additional organ beyond the area of complaint, and there's my level 3. Level 4 requires some additional detail. So the documentation guidelines for coding level 4s has confused a lot of people over time. I'm not going to go into all of the issues, but let's just talk about getting 4 or 5 organs into our chart for a level 4 patient. It is not hard to do. You can get 5 organs just by looking at a patient. By conversing. You can get neuro and you can get psych, and you can check the chart to get a vital sign statement. There's 3, right? Eye, can you get eye? Yeah, you can get some eye. You can check their skin. Are they cyanotic or not? Okay, you don't have to palpate anything. You can just look at them. So not hard to get content, to get 5 organs out of a physical exam on any patient. The comprehensive physical exam requires 8 organs to be considered what's called a general multi-system exam. One comment about 8 different organs. One comment on each of 8 different organs. Not a lot of content. So, easy to get there in the physical exam.
What's the difference between simple and extensive documentation for the affected?
That's a good question. The affected organ, and this does get into the coding controversy a little bit. It's expected, if I wanted to do limited additional detail, I would have to provide extensive detail about the area of complaint. An example would be an abdominal pain. An abdominal pain, there's a fair amount of content in a physical exam. There's a number of, I've got a number of quadrants to check for. There's a fair amount of content. So if I got extensive detail in one area, the area of complaint, I would need only limited detail of a limited number of additional organs. However, if I got simple content about the area of complaint, now I need to add additional content of other areas with limited detail. So now I need to push the number of organs up to 5 if I'm only going to get a little bit of content out of one organ. But if I get a lot of content out of one organ, then I can do a little bit of content about 2 or 3 more. That's the coding sort of rule behind that. So that's just to say, if you only got a little bit of content on the area of complaint, get me 5 organs in total. But if you did a whole lot of work, like this is, the example is often the pelvic exam. There's a lot of content that comes out of the pelvic exam. There's a lot of things to look for, right? So you do a pelvic and you just kind of feel like I've done a lot of work here. And that's kind of true. There's a lot of content, all right? It is what it is. So there's a lot of content. Now I really only need to examine a couple of additional organs. Okay? So that's the concept. The level 5, we've talked about. Here are the 12 organs that you would classify your comments into. Coders, you're familiar with these 12, right? And again, you don't have to follow, nor should you follow necessarily, the content, the format of EPIC. Like if they do a CVA exam and they call it, I don't know how EPIC classifies a CVA. Do they call it a back exam? Do they call it musculoskeletal? You know.
Genitourinary.
Yeah, I know. Okay, does it? All right, good, fine. Because,
It is under abdomen.
right, it might be under abdomen. Well, no, checking for CVA tenderness? It is under abdominal. Okay, well, that's why I wanted the coders to recognize that's a genitourinary. It's not a GI exam. So even though it comes out in the format, well, that's not a good example, but if it came out in the format GI : no CVA tenderness, we would classify it under the genitourinary because that's the content. See what I mean? The format is not relevant. Because I called it, and so let's think of some others. HEENT. So the eyes, if we had under HEENT, so if we had under ophthalmologic, extraocular movement intact. Well, that's an eye exam, but it's specific to neurologic function, right? So that's both an eye and a neuro. From a coding perspective, I may choose one or the other, whichever I need, frankly, because it's content in both. So that's where I want to say, don't just follow the format of the record, but code based on the content that's in the discussion. Because the format's irrelevant. Same thing with system review. Okay, and that's the whole point about we can pull system review out of that free text that the doctor does up in the HPI. Because it's about the content. You got to be able to read content and understand an HPI complaint, what organ does that relate to? And therefore it becomes, because he said up there that there was some minor GI distress in the HPI complaint, I need to recognize that even though there's no format for that, that's a GI complaint, and I've got a system review for the GI organ. See my point? Okay. What do we do when we're prevented from getting the complete physical exam? And it does happen if you're moving patients to the cath lab. Depending on how your trauma patients work, sometimes trauma is, trauma teams here, they're down and you have trauma, you have trauma service, so they're coming down meeting the patient, basically at the same time you're there, right? So you got airway and they got everything else, so you document the organs that you have ability to document. But if you don't get 8, you may complete the physical exam by saying, a complete physical exam was prevented due to treatment urgency. Because it doesn't make sense, that's an obvious concession, because it wouldn't make sense to say, hold on, don't let that patient go. I got to check to see whether their toes pink up all right, and move the patient, and the payment system recognizes the value and the complexity, frankly, of having to do the work without all the content that you'd like. So, just mention why the exam was abbreviated. Okay, so here's a little scoring worksheet for the coders. How many elements do I need in HPI for? I need 10 in the system review. I need 8 in the physical exam, and I need high medical decision making, and that constitutes my level 5, and so forth. Okay? Okay, now we start talking about medical decision making and the heart of evaluation and management. So this is where the money is. It's in the thought process. So let's pay particular attention to the content here. I'm going to take you through, I'm trying not to spend, I'm not going to teach this like a coding course, but I do want you to understand, physicians, providers particularly, I want you to understand how the content in the medical decision making translates into the visit level. So you know, you got a sense of what your work is worth in terms of the coded visits. Okay, so we see that for a level 5 here, a level 4 or a level 5, that's actually incorrect. That belongs over here. I don't know how that is. Oh, I changed, I know why it happened. Okay, sorry about that. 3 and 4 are the same, moderate complexity. High complexity stands on its own. But the difference with medical decision making is that I need only 2 of these 3 components to correspond. So if I have extensive management options and high risk, but only moderate or even limited data, I may still score for the highest level of decision making. And it makes sense because you don't have to do a lot of testing in order to get a level 5. There's that sort of coding, well, it's an unwritten rule that everything always has to line up for medical decision making. That's not true. And sometimes it's felt by the physicians, if I did more testing, I could get higher levels, right? So I'm the guy who doesn't get the level 5s because I don't do a lot of testing. Well, if coding is done right and you're documenting your medical decision making, that will not be true, because you'll hear me say this more than once, that deciding not to do a test gets you all the credit of having done it. And the payment system allows for this by recognizing that it only needs to correspond 2 of these 3. So we code to that which meets or exceeds 2 of these 3 key components. Okay? So I can have a patient with only 3 points of management options. And an example would be a patient who goes home. 4 points is a patient who gets admitted. The additional management options are we choose to admit, they get 4 points for that. But a patient we send home gets only 3 points. But they had a high risk presenting problem, and I did significant amount of testing to rule out the need for admission, and they ended up sending them home. So they only got 3 points here on management options, but 4 points for data and 4 points for risk. They're level 5. Okay? So I want you to see how this works. Okay, management options, data and test to review, risk of complications, morbidity, mortality. So the key to communicating the value of ED care, a well-written ED course, not just what you found, what you considered, why you did what you did, and why you didn't do what you chose not to do. Okay, like I chose not to admit them. Well, on an ankle sprain, that ought to be obvious. But on an otherwise, possible admission, but you're willing to take the risk to send them home, I think you ought to get credit for that. And I think you ought to stand up and say, I'm comfortable sending this patient home. And I'm going to do that. When you remove the question, when you recognize that an admission is a potential, right thing to do here, but you've chosen to discharge them, mentioning that gets you the credit as though you had admitted them. Testing. I mentioned the CAT scan. You chose not to get a CAT scan on that kid. Mom said, please don't, irradiate. Can you do something else? I read that article in the paper way back when about, way too many CAT scans on children, and, so can you just not do that? Is that okay? And he said, okay, fine. Now I got your kid here for the next 5-6 hours, right? Because you're not going to send him home right away. So we're going to observe, which, by the way, becomes a reason for doing emergency department observation care. But I want you to get credit for the high complexity and the additional risk of choosing not to do, or a patient who is morbidly obese, may not even fit through the CAT scanner, but the results are probably not going to be dispositive, so I don't know the value of doing one. Okay, you were effectively prevented from getting that test that would have been useful. Like to know that, because that's additional complex diagnostic testing that could have made this a 5. Tell me that you chose not to get it and why. Okay, so tell me what you chose not to do. And then finally, how did the patient respond to your interventions?
Can you go back to that last slide? Mm-hmm. Not get this number of possible diagnoses or management options. I don't understand.
I'm going to talk about that. You're right. I've hinted at it a lot, and yeah. So let me get into that in a little more detail. So documentation guidelines clearly indicate that the number of and types of diagnostic tests may be an indicator of the number of possible diagnoses. But other factors that increase the complexity of decision making by increasing the risk of complications, morbidity, mortality should also be documented. This is the documentation guidelines way of saying that when you give differential diagnoses, coders are to recognize that those play into the risk of the presenting problem as well as your final diagnoses. So your differentials are the other factors that play into the complexity of medical decision making. See, if you order an amylase on an abdominal pain patient, I'm not even sure we do that anymore, but if you did, it's kind of obvious what that's for, right? We're kind of looking for pancreatitis or something related to that. Okay, so I can make an inference. If you're ordering cardiac enzymes on a patient, I can reasonably infer that cardiac ischemia is a working diagnosis. Coders will make that determination. That's part of our training and experience. So we can do that. We can take your tests and infer from that your differentials. But if you don't test, we can't infer from your physical exam what your differentials were. And there's where we miss the meat. Because a lot of times, you're documenting in the physical exam what you're worried about, like saying, I don't think there's any meningeal signs in this kid. But you don't say that meningitis is a working differential. You say, well, but I set it up in the physical exam. Payers have the right, and I think reasonably, to ask, does the physical exam, did you use your own physical exam findings in your medical decision making? It is an occasional oversight to do that, meaning that we will take patients with weak and dizzy and never do a neuro. Did we not consider? Well, no, of course we consider. We just never went, it's not, you don't normally, well, it's not true. No, we should do them. We should do neuros on weak and dizzies. Do we forget sometimes? Yeah, we forget sometimes. So, the payer reasonably says, what's the content of the physical exam doesn't tell me enough about what your differentials are. I can infer them from the tests. I can't infer them from the physical exam. So you're going to have to tell me what you were worried about. That's my point. Okay? Now, Dan Sullivan got a lot of great points, and I'm not going to spend a lot of time on this, but here's his 7 deadly sins of documentation and risk management issues. And all of these play right into reimbursement. Because everything Dan tells you you really ought to do for good risk management plays right into strengthening your claim for the higher level exam. Things like reevaluations, repeating abnormal vital signs. It's just really very useful in supporting level 5 for higher level claims to get repeat vitals on a patient who came in with abnormal. You got a blood pressure 160 over 100, and they may end up going out the door at 160 over 100. We're not going to treat that, right? That's not aggressive hyper. So it's an. But should we check that? Yeah. Does it show ongoing concern for it? Yes, it does. And it's great for painting the picture of the patient's increased complexity of risk of presenting problem. So you're just going to build right into the reimbursement system doing the kinds of things that he talks about, like the detailed neurologic in patients with pertinent presenting problems. Now, the point of my mentioning, Dan, is that he is of the opinion, as am I, in distinction with some other risk management consultants in emergency medicine, who would argue that a differential diagnosis, that you should never put a differential in a chart unless you've completely ruled out that patient's problem. That makes no sense to me. That mentioning something that you didn't completely drive to conclusion increases your risk. Because it makes, to me, perfect sense for the plaintiff's attorney to say, you mean you didn't even think about? You didn't even consider for this patient? Well, of course I considered. We always do. Everybody knows that. You didn't mention it. Doctor, how can I be inside your mind at the time of the visit if you don't tell me what you're worried about? And this thing that the guy died of, if you were at all concerned about it, you probably would have said, and I really don't think he has any. So, his point is, so he gives this example, one court case where, there was a reasonable if there was a reasonable differential diagnosis and assessment, not getting the answer is not malpractice. The court says, in other words, negligence consists in not foreseeing and guarding against that which is probable and likely to happen, not against that which is remotely and slightly possible. So if it's a probable, it's a possible, we mention it, we guard against it because we comment on it, right? We bring it out, we make it, not implicit, we make it explicit, that while we didn't rule it out, we didn't think it was, that big a deal to have to completely rule out, but we did consider it. And the court, ultimately, the jury found that in this case, physician was not liable, and the differential is what made the difference effectively. So then he goes on to recommend all the kinds of things that I'm talking about too, including creating incentives for high quality documentation. I think that makes sense as well. And things like documentation should occur during the patient visit. Documenting charts 2, 3, 4 days later has problems, has risk management issues, but also it's one of the reasons why charts don't get coded timely and why they don't get coded accurately sometimes. If the physician takes a long time to finish the charts, sometimes they slip through the billing system and causes problems. All right, enough said about that. We'll talk more about differentials in a minute. So the ED course and medical decision making are where we have an opportunity to communicate the value or sell the value of our care. Okay. Here's a patient. History and physical is irrelevant from my point. That the patient, here's their lab work. Final diagnosis is hyperkalemia ketoacidosis. But the ER course basically says 10 mics of morphine, a little Zofran, some Caxylate, and I sent them upstairs. Okay, next. That doesn't tell me, that alone doesn't tell me how you got here, and it doesn't really do justice to what you did for the patient. Okay, the morphine, did it work? Yeah, it gave him nausea, so you got him the Zofran. Hope that worked okay. But how about that morphine? Did you give him 10 mics all at once? Did you give it titrated? Did you give him separate? How'd that go? And a little more interaction with the labs, but their ED course, where they're in the emergency department, 20 minutes, kind of the way that record looks, right? Okay, we just okay, done. Now, maybe that's how that case went. Ketoacidosis and hyperkalemia, I kind of doubt it. I mean, you're loading them with fluids. You know, what else are you doing here? This is just way too terse. Now, this is a critical care case. I'll tell you right now, that deserves critical care time statement. That's left off, but that's not my point. The point is that more of your thought process, your concerns for the patient, the level of their potential crisis, is it real now? Are they in distress now? You know, more detail in the ER course in medical decision making is vital to managing this patient. Okay, so we're going to talk more about that. Now, let's get into medical decision making and how we score it. I'm not going to try to turn you into coders, but I want you to understand the content of how this works. Now, this is sorry for the small print. This is the document upon which the Medicare documentation guidelines and the scoring systems that virtually all of the Medicare carriers in the country now use their audit tools based on this document. So I want you to see the original document. This was actually developed in 1992, along with the Medicare documentation guidelines. And I want you to see the things that it happened actually to be the Marshfield Clinic that developed this documentation tool, but it has become the foundation upon which most of the carriers in the country are auditing your records right now. So what are they looking for? Well, remember there are three content issues in medical decision making are number of management options of diagnosis, amount and complexity of tests, and risk of morbidity and mortality. So there's a worksheet for each of those. Here is a draft step-by-step summary of the process can be used by carriers in determining complexity of decision making. Step 1, evaluate number of diagnoses and management options. So first, is it a self-limited or minor problem? If so, it gets 1 point. If there are 2 self-limited or minor problems, it gets 2 points. For each established problem that is inadequately controlled, worsening or failing to respond, 2 more points, an established problem. For 1 or more presenting problems not previously identified or diagnosed by you as the provider, a new problem not previously diagnosed for which additional assessment, consultation, or diagnostic studies are not required, gets 3 points. And finally, for a new problem that does require either additional assessment, consultation, or diagnostic studies being ordered, planned, or performed, 4 points. Now, what is this scoring system? Well, here's the bottom line. Every patient who comes to you is new to you by the scoring system, okay? Not necessarily that you don't know them, because the guy's a frequent flyer. He's here all the time. But by the payment system, he's new to the practice of your practice of emergency medicine, okay? So every patient basically comes in, except the needle sticks and simple, insect bite that's gone away and, worried well, the super minor problems. But for virtually every other patient, they come in with 3 points. They are a new to you, non-minor, that is, it isn't going to go away on its own right away, doesn't need physician evaluation. They are a new non-minor problem, and the only question is, are you going to do more workup or none? So they come in starting at 3 points, okay? Now, that's not true about the whole healthcare system because, in the private setting, in the primary care office, they're established patients. So the bulk of health care delivered to other patients is done down here. When a patient comes to the emergency department, they're coming in starting with 3 points of management options. Okay? So now you see why we need you to comment on what did I decide to do or what did I decide not to do while they were here? Because the scoring system is now going to look at assessment, consultations, or studies that you either ordered, planned, or performed. If you ordered that they be admitted, or you planned for it, you ask someone else to admit them, right? They get 4 points. Now, what if you wanted that to happen, that was your choice, but you were prevented by someone else? No one would admit them. No one would take, no, I'll see him tomorrow morning in my office. No, wait a minute, I don't know whether if the guy didn't show up tomorrow in your office, I'm not comfortable. Oh, no, he'll be there, absolutely. Oh yeah, I can see him. I can see him at 9:30. No question. Send him on. Okay, cross my fingers, because I really think he needs to be in the house. But if you're going to see him tomorrow morning, fine. You were prevented from admitting that patient. Okay, sphincter tone on that discharge, a little higher than your average, right? So you got some risk associated with that patient going out the door. Commenting on that gets you the 4 points of an additional assessment that would have been ordered, planned, or performed, but you were prevented from doing it. Same thing with a CAT scan. That is, a CAT scan is additional diagnostic studies, complex diagnostic studies that you would like to have had ordered and performed, but were prevented. So I get 4 points by commenting on this intervention that I was prevented from doing. Okay? Now, doing things like calling a consult, that gets you the additional 4 points. So you got to call neurology because they want to know about every potential stroke patient. You say, well, look, I don't think this one's not thrombolytics. Okay, guy's been down for like 4.5 hours. It's really outside the window. But hey, I just want to let you talk to you about this. Okay, we would like to admit them. That's additional assessment. Or you call, or you call, like that patient that the doctor says, I'll see him in the private office. If that's a consultation, I need to know that. Just calling a physician saying, hey, we're admitting your patient. I'll see him tomorrow. If it's actually a consultation, that is, if information is exchanged that will help you discharge the patient safely, that's additional consultation, and you get 4 points for that. But I need you to tell me, not just that I talked to Dr. Jones, but I talked to Dr. Jones, and he feels that this is a persistent problem that can be managed outpatient. So I'm now comfortable with discharging the patient. Does that happen? Yeah, from time to time. So we need to know that. Because now I've got 4 points for the additional consultation, right? That's what got the guy home, was I did additional consultation. So we need you to document that. Make sense?
Go ahead.
The subsets of medical decision making.
Yeah.
These point system is referring to both the number of
Yeah, that's a good point.
And complexity of.
In fact, the language is written that way, but when you go to score it, it's really only management options. It says number of diagnoses and management options, but when they created the scoring tool, they didn't score for additional diagnoses. So it's a little bit of an oversight. I'm not quite sure why it was done that way. But we'll talk about the additional diagnoses when we talk about differentials, but that's in the risk category.
Okay, but this scoring system then is only referring to the first subset of medical.
It is. Right. It is only the first subset. You're right. Okay, so here's a little cheat sheet on that. New non-minor problem, 4 points. New non-minor, no diagnostic studies, 3 points. Yeah, I'm not going to get into that. Okay, so here's the second step. So step 2 is evaluate the amount and/or complexity of data. So for the following system is used to determine whether the amount of complexity is minimal, limited, moderate, or extensive. First, we look at the order and/or review of the report of anything out of the pathology series of CPT. That's any of your lab studies. If you order one lab study or order a dozen, you get 1 point. Okay, CBC, cardiac enzymes, anitroponin, I get 1 point for that because they're all out of the 80,000 series of CPT. But I then also order an X-ray for that patient. Well, for the order of one or more tests, I get an additional point, right? And I'm going to order an EKG. Well, an EKG happens to come out of the 90,000 series. That's considered a medical test versus a radiographic test. So now I get 1 additional point for an EKG on that. And by the way, it would be the same if you ordered a rhythm strip.
So EKG and rhythm strip, what else is in that?
Peak flows, don't do them anymore. Pulse ox.
Pulse ox?
Yeah, if you look at a pulse ox, that's in the 90,000 series, yep.
So would you,
Spirometries.
so if you check, we have a box that says review vital signs. Pulse ox is considered.
Physical exam. Well, no, it's not. Well, yes and no. It is and it isn't.
You have to specifically say review the pulse ox.
Look at the pulse ox, right.
And comment on
Pulse ox is normal. Yeah, pulse ox is 98% to room air.
which is normal.
Yeah, which is normal. And now you've interpreted it, and now you've clearly gotten that
You
content.
mentioned patient was hypoxic or like sats were low. Does that still count?
It should, but it's best to reference the pulse ox showing you that.
It's the whole sat.
Yeah, right. Yeah, it's just best. Okay, so ordering. So 1 point for ordering labs, 1 for an X-ray, 1 for an EKG. I got 3 points on that patient. Now I go down to read complex test results. For the direct visualization and independent interpretation of a specimen image or tracing, which has been previously interpreted by another physician, wouldn't that be nice? But that doesn't happen in the emergency department. Nobody's reading our X-rays for us, right? But for the direct visualization and independent interpretation of a specimen image or tracing, do we do that? Every X-ray and every EKG. Okay? Even if radiology were elbow to elbow with you, reading that film, if you were directly visualizing it and making your independent interpretation, you get 2 points for that.
It counts for rhythm strips too?
It does. Well, yeah, but you're not going to. Yes, it does. Right. Yeah. Yeah, it does. So if I order an EKG and order an X-ray, and I read them both, I now have 1 point for the EKG, 1 for the X-ray, 2 more for the interpretation of the X-ray, 2 more for the interpretation of the EKG. I now have 6 points. Throw in the 1 point for the labs, I now got 7 points. How many do I need for an extensive? I only need 4. So you see, it's not hard in emergency medicine to get level 5 data on these patients, okay? Direct visualization, 2 points. Oh, and by the way, if you decide to look at old records, get 2 more points for that. Talk to EMS, that's getting history from some other source. That's 2 points. So documenting it. It's not hard to get points here, guys. Emergency medicine is an intensive work environment. So a ton of data is being gathered by you, and you get credit for all that.
Some of those sections are different than others, like when you order 12 lab tests,
Yeah.
1 point.
Yeah.
But if you interpret,
Go ahead.
the other, like you say, you're interpreting an EKG, you're interpreting a rhythm strip, you get 2 points for each of those where
You wouldn't. You wouldn't.
you don't.
No, you only get 2 points for
in that section.
any medicine section, 2 points for any
Doesn't matter
X-ray.
how many you do.
That's right. If I looked at 5 films, I still only get 2 points. But if I looked at 5 films and an EKG, that's 4 points because they come from different
Different.
sections. Right.
And this is just for the level of
That's-
service stuff. That has nothing to do with how those are built.
Correct. Has nothing to do with whether we're going to bill them. Nothing. Okay, coders, you know how to count data points? Right, you can count additionally, kind of the way we described. Have you heard anything that I've talked about in terms of data that is new or different from where you're doing it?
Just the 3 points for the new problem, no additional work.
Oh, okay.
Assessment.
Oh.
No matter how many diagnoses you have that are new, if you don't do any additional workup, for us on the physician's portion, we only could give them 3 points, no matter how many diagnoses they're seen for.
Oh.
'Cause that's what Medicare tells us to do. Just count. You can never get more than 3 points.
What?
For new problem,
New problem.
no additional assessment or workup.
Oh. Well, yeah, right, that would be correct.
Right.
But if I did lab testing,
Oh, yeah.
if I did testing on that patient, it now goes to 4.
I'm sorry, I'm not under the data.
Oh, okay. You're talking about back in the...
So wait, now, if you have chest pain and you have a sore throat, how many points do you get for that? On what she's saying? 3? That's it?
No. You mean, wait, give me that again, question?
Chest pain and sore throat. Now, do any tests or anything?
Right. The chest pain, in terms of management options, the chest pain is a new sore throat might be a minor problem. It's irrelevant to the scoring because I'm going to have 4 points of management options coming out of the chest pain
Well, I don't do anything. Let's say I don't do anything.
for the chest pain.
Yeah. You said we can see chronic people. We have, for example, a chronic person who comes in all the time with exactly the same complaint that you see about once a week.
Right.
Chest pain.
Chest pain.
And
But you don't do the EKG, you don't do the enzymes, you don't do the chest x-ray.
nah, sometimes you don't do it.
That's fine, I
You
understand.
would get a 3 for that.
3, right. Yeah, if you don't work them up, they get 3 points.
So if you got chest pain, so
Yeah, you don't,
no matter how many diagnoses you have, what if I had chest pain?
Correct.
Belly pain.
doesn't matter,
Still 3.
doesn't matter, right.
So how do you
It is the total management of the case, right. The number of diagnoses does not play in at this point. It plays in when I go to risk, but go ahead.
Is it considered fraudulent if I'm trying to boost my medical decision-making score by putting in something that's not necessarily relevant to the patient's complaint? Say a young female comes in with UTI symptoms, will I get a point for ordering the lab test, which is the urinalysis? I get 2 points for interpretation of the lab test, but I want to get to 4 or more, so I comment on her pulse ox and say that it's normal.
That was kind of a long question, but it started out with, would it be fraudulent if I up-documented my medical decision-making?
Well, I mean, the pulse ox isn't-
And the answer is, yeah, don't do it. Yeah, but the bottom line is it wouldn't have helped you anyway. I think is where we got on that.
Right, because it's only going to end up.
Yeah, because the risk isn't going to take you to a level 4, a level 5 anyway.
Right.
So you can throw in a whole bunch of data points there, but management options or risk aren't going to get you.
But can you still bill for the interpretation of the pulse ox?
Oh yeah, you can. Right.
might as
Well, let me back up. No, you can't anymore. You can't. No, and in fact, that's right. And in fact, yeah, we've started to advise not to bill for pulse oxes. CPT doesn't like them. They say, well, you have to own the equipment, and in emergency, we don't own the equipment. And it's kind of it's a back and forth issue, but we don't bill for pulse oxes anymore. Bottom line, we don't bill for them.
Medical necessity comes into play.
Well, yeah, but I can argue for a medical necessity and a pulse ox on a lot of presenting problems, But anyway.
See, I think that gets back to my original difficulty with this whole system in general. Is again, I'll just use the same chest pain patient.
Okay.
That we all here know who I'm talking about.
Okay.
Okay. And I document my butt off from a medical legal standpoint, purely medical legal standpoint.
Yeah. Right.
This man has no business being billed a level 4 or level 5. He's simple. It's the same chest pain he has all the time. And when it's different, he'll tell you it's different. But the thing I was worried about is now he's going to get a big bill. He's depending on where he's got a job and not having his insurance.
Yeah. Right. Right.
Based on what I'm documenting, which is nothing to do with care, has everything to do with protecting me. And so, medical legal. That's where I struggle with the documentation and that, and specifically the billing of that case. Yeah,
there's a lot in that question. One of which is it has nothing to do with his care. It's only about protecting me. And I would argue that if it's not about his care, it's inappropriate to order the tests.
No, I'm telling you don't necessarily order tests. You do a very, very extensive history and a very
Okay. All right. Right. Exactly.
all that stuff.
Okay.
And based on what you said, now he's already got a 3 for this, and I can document, quite well enough that he's going to get billed a whole lot higher than I think he should be billed.
If it's benign chest pain and you know it from the start,
Yep.
it's not going past the 3. And no matter how much you write. It's not going past the 3. I think I could argue for anxiety-related chest pain being a 4, because anxiety is the problem, not.
This is more of an IQ developmental.
Okay.
Other patients might-
Good example. Good example. It's IQ specific, so patient does not have the faculty to sort of discriminate his medical problem.
Right.
Okay.
And you see, there are other occasional cases like that where you're documenting. It has nothing to do with, and you worry about how is this going to get billed out. But I know that I'm doing this for reasons. I don't want to be billed that high, but I have no say or control over that.
Well, but again, I would argue that it should be billed out at the level of care that was delivered. At the level of care that was delivered.
I'm sure that's what happens. Like I said, I struggle with that.
Yeah, okay.
If we build him to level 6, maybe he won't be doing that.
Back twice as much because he's off the curve. He's got above the curve or something.
Okay, so we were talking about data and points. Now let's talk about risk. Okay. A risk of complications, morbidity, mortality. So here's our risk table. There are 3 types of risk. There's risk of the presenting problem, risk of the diagnostic procedure, and risk associated with the management options. Emergency medicine, what we're principally interested in and governed by, is the risk of the presenting problem. So if it's a self-limited or minor problem like a cold or an insect bite, that's pretty low risk stuff. Okay, that's your examples of level 1 type patients. But if there are 2 or more self-limited minor problems, I have a cold and sinusitis. They're both going to go away on their own. I can give you some comfort stuff, but really this is not a disease process. Okay, it's a viral condition, it's coming and going, so no big deal. I'll give you a low complexity if you got 2 or more of those, but you're not going past that. Okay, or a stable, chronic, well-controlled illness. Now, moderate complexity, here's where the majority of our patients reside. Mild exacerbation of a chronic illness. 2 or more stable chronic illnesses. Well, if they're stable, we don't see those patients. Okay? Undiagnosed new problem, uncertain prognosis. That's a whole bunch of our patients. That's why they come here. I don't know why I think I have blood in my stool. Oh, really? Did you eat a lot of beets yesterday? Yeah, that'll do it too. Okay, but they don't know, right? So, oh my gosh, I'm worried. Uncertain prognosis. Coming through the door. So, like rectal bleeding. So, those are our patients. Acute illness with systemic symptoms like a pneumonitis, and an acute complicated head injury like a head injury with brief loss of consciousness. So you see they kind of go up in risk as they go down the column here. Many of these but some are going to be 5s. An acute loss of consciousness as a result of head injury, many of those are going to be 5s. We just know that neural bleeds happen more often than we used to think they happen, but they happen. And so some of those are going to be 5s. And anyway, so that's the bulk of our patients in terms of risk of the presenting problem. And then the high risks are patients who have, again, not a final diagnosis, but a presenting problem that is a chronic, consistent with, is really what this should say. A chronic illness, it should be a presenting problem consistent with a chronic illness with exacerbation. A presenting problem that is consistent with an acute or chronic illness that poses a threat to life or bodily function. Those are our classic level 5s. They may not be having an MI, but they have a presenting problem that is consistent with an illness or an injury that could threaten their life. Severe respiratory distress. Like this one, severe rheumatoid arthritis. Well, turns out the documentation guidelines, I actually heard Dr. John Hall present this back when they rolled them out in 1991. He was on the advisory panel with CMS. He's a rheumatologist. And he wanted his rheumatology colleagues to know they could get level 5s too. So that's how we ended up with rheumatoid arthritis as one of the classic examples of level 5 kinds of presenting problems. Not likely. I do want you to note, folks, depression with suicidal ideation is a level 5 risk. Now in emergency medicine, we're not going to talk psych patients out of being crazy. We're not. This is not what we're trained to do. We're not good at that. We're not going to manage their psychosis long term. What we are going to do is make sure that they don't have an underlying medical condition that either exacerbates or causes the mental instability they feel right now, right? And we're going to make sure they don't hurt themselves or someone else in the process. That's what we do. Those are level 5 patients, okay? And I want you to recognize when you treat those that your physical exam and your diagnostic workup, you need to recognize you may be the only, this is going on tape, so edit this, but you may be the only real doctor they see for throughout their entire stay. I mean, real doctor who's going to manage their entire medical condition. I might even say that about like some orthopedic patients, who come in with a medical condition. That's why they fell. But now they're going to get their shoulder surgery or whatever else. But they're not. Those guys are not dealing with the underlying medical problem. You are. Okay. So the way you write up your conclusions about, and the way you describe the patient's case, and the way you discuss the medical implications of what they've got, may be the real only diagnostic evaluation they get out of the healthcare system, until the next time they see a real doctor. So treat these patients effectively, if you would, for what you can treat them for. And that is, how'd you end up this way? What were the exacerbations? What are the conditions that, bring you to this point? And then, evaluate the medical thing to make sure that that isn't a key contributor. Even the crazies that you see all the time. This is a little plea for, assistance with the mental health system, which is absolutely frickin' broken. Mental health in the United States is an embarrassment to the country, I think. And we feel it in emergency medicine more than any place else because patients have no other place to go except you. And I know the frustrations you feel about not being able to manage them because you can't get them you can't get them on the floor for like 5 days, 6 days. I have psych patients in my client hospitals in LA that sit there for 7 days. We're managing them acutely throughout their entire stay. Because then finally, they just kind of get better from just kind of having people caring about them for 5, 6, 7 days, and we discharge them out of the ED because we can't get good psych care. So I know the psych crisis, and I'm just saying to recognize the payment system believes those are level 5 patients. So do the right thing for them, treat them that way, document it, and those are 5s. Even if you're just doing a quote-unquote psych clearance. Now, a real psych clearance is patients already been seen by a psychiatrist, or so like it's an alcohol abuse thing, and they're going to the floor, they've already been admitted. It's like, okay, stop in the ER, because there's real doctors down there, and they'll do the medical evaluation, and then like run you right upstairs. Okay, that's a psych clearance. You're not managing the medical emergency. That's already been done. All you're doing is the clearing to move the patient upstairs. Okay, that's a level 3 or 4. All the other stuff, the acute psychotics, the schizophrenics, the suicidal ideations, those are 5s.
What about ones that are, because we have inpatient psych care in their hospital, so we get a lot of people who are already, even if they are suicidal, they're already knowing where they're going.
Yeah.
Come to us for medical clearance. Is that, since we already know where they're being disposed of,
yeah. So
it becomes a level 3 or 4?
Well, not necessarily. Again, it depends on what the related problem is. Is it drug related? Do they have like a drug concomitant condition? Do they have a is there some other, are they diabetic as well, so there may be some other issues playing into this. Some of those are going to be 5s already. But if it's truly, like you said, they're a psych admit, they're going to the floor, they're stopping into the emergency department to get their evaluation, probably only a 4.
We're being used for lab draws.
Yeah, right, exactly. And if they're only being used for a lab draw and a quick, hands on the belly and the heart and check the vitals, it may well only be a 3. If you're not dealing with any of the psych emergency stuff. Okay, that you got, but it's driven by what is their medical, what is their total overall condition while they're in the ED. Like that direct psych admit that needs a guard at the bed because they're so, they're so agitated, or you got to knock them down with Haldol, that's critical care. If they have the potential to do harm to themselves or someone else, high probability, we'll learn in a few minutes, high probability of a life-threatening condition is critical care. They don't have to be in crisis, but if they got the high probability of going there, of deteriorating, they're critically ill. So your medical clearance becomes now, let's just be sure they don't kill themselves or somebody else.
So what's the limit to that?
Limit.
Let's say you get somebody that's actively suicidal, they need a sitter, and you're saying that's critical care time. Do you bill 7 days of critical care time?
No. We'll talk about it's your time of attention.
You don't pay for it anyway.
Your time of attention, and we'll talk about how to mark that time. But it's for whatever amount of time over each of those days that you spent giving attention to the patient while they had the potential to do harm to themselves or somebody else. So in some days it may only be, poking your head in 20 minutes. You're checking the chart though. I would venture that if that patient's in your pod, you're going to at least look at the chart and look at the patient once or twice, maybe 3 times throughout the shift, just checking on them to see how they're doing. That's time of attention, as well as looking at any note, if there's meds given, checking any of that stuff, time of attention. That's all. We'll talk more about it. Okay. Management options. Not much of this pertains to us.
Can you go back to the test? You didn't talk about that.
Sorry?
Section B. There.
Oh, diagnostic procedures, thank you. Yeah, it really kind of not pertains to us because this is the risk of the procedure itself. And for us, we're a cognitive service, not a procedural service. So what this says is the risk of doing the lumbar puncture represents moderate complexity. The reason we're doing the lumbar puncture, the presenting problem, is a high-risk issue. But the puncture itself, is of only moderate risk. The risk of doing an EKG, it's like all the risk that's involved there is like when you pull it off, the hair comes with it on the guy, right? So there's not much risk, except that the underlying condition is what we're really concerned about. So this one doesn't inform us very well.
About intubations or cardioversions?
Yeah, those again are not, they're not listed here in terms of interventions because what would be more relevant is the reason why you're doing it. The medical condition that promoted those diagnostic procedures. That's why I say this doesn't pertain to us as much as the medical reasons why we had to intervene. That's all that stuff.
You did so many cardioversions, way to replace the flux capacitor.
Be careful, I got some extra dams here.
He hits anything that moves. So risk of management options. This one helps us a little bit because we see that if we do prescription drug management, it turns a level 2 into a level 3. An otitis media that is not infection based. And if we're not going to treat it, then it remains a level 2. But if we give script, it becomes a 3. Or we change the script that a patient is on. Or we tell them to take less of or more of. That's drug management. So that's an indication of level 3. And these are important to document. Do you guys do provider and triage? Where you go out and see the patient in the waiting room? Okay. Because, you know, in flow issues, it's one of the ways to deal with ED overcrowding. But a lot of times in provider and triage, some of that stuff gets lost because you go out and see the low acuity stuff, keep them vertical, you know, the verticals keep them vertical, and like just see them and say, you're fine, you can go home. You know, here's like your discharge, go. I don't even need to put you in a bed. You know, and so, but sometimes we forget to mention the scripts that we give in that circumstance, so those go out as 2s and belong as 3s. So if it gets into the record, scripts are an important issue when coding. We want to know that you manage the prescription.
Actually, Karen, do you guys see that we wrote scripts if you don't mention it in the notes?
Well, sometimes if they're listed at the top, the medications, and it'll list all their medications and view on the bottom. I mean, I can match it up by date. Let's say they were seen August 22nd. I can go into that script, so you wrote it. So yes, then I can see. But if it's not in Epic, no.
No, it's not in Epic.
Within the encounter in Epic, you should be able to see it. Like if you look at the entire encounter, it'll show what the discharge medications were.
They have been, all of them showing up, but lately I've noticed some of them not. I'll pick it up from the bottom, you'll say script was given, but there's nothing listed on the patient summary screen that they were reading the script. And that's just a recent change, very recent change within Epic.
Upgrade.
Upgrade.
Would you also agree that even deciding not to tell?
Oh, good point.
Quit taking
Yes, right.
It's still a
That's
management.
management.
That's management, exactly. That's a very good point. Yeah, stop taking. It's making you crazy. Yeah. And then parenteral controlled substances, narcotic-based meds, parenteral controlled. Those would, while they're associated with high risk, normally don't say, just because we gave a back pain patient, you know, a narcotic-based med, doesn't automatically make it a 5. I just want you to understand that. You know, the other stuff has to correspond as well. And frankly, you know, this would not, if the risk of the presenting problem was not associated with a 5, the fact that we gave them a narcotic is not going to make it a 5. From my perspective, medical necessity is not there. If the risk of the presenting problem isn't there, I'm not going to turn that into a 5. But we do want to know if you gave narcotic-based meds, because they will turn 3s into 4s. That is a reasonable difference. Okay, so I know the whole pain management thing and narcotics and you know, we're hesitant to do that for lots of reasons. But anyway. Okay, this is just an example of one Medicare carrier that built a auditor's instruction, auditor's worksheet off of the documentation guidelines I just showed you, the worksheet. So they go through and score the chart, and they come up with the scoring value on each of the components. You know, so there's like the exam. They check off the exam components they found in the chart, and then determine the exam level and so forth. So I want you to see that these scoring tools that carriers are using were driven largely by the medical decision-making that we just discussed. Okay, so let's talk about the nature of the presenting problem. Medical necessity is, as it says here, the overarching criterion for payment in addition to the individual requirements of a CPT code. If it would not be medically necessary, appropriate to bill a high level of evaluation when a lower level is warranted. If only a lower, the more you write does not necessarily make the higher the bill. If a lower level of service was warranted, you can order tests out the wazoo on an ankle sprain patient. You're not going to get more than a 3 unless you can justify the medical necessity of the tests you ordered. So that's, on the face of it, just should make sense, okay? So that's why we pay so much attention to the nature of the presenting problem, is because it is going to drive medical necessity of the workup that you've done. And that's why I want you to document that in your medical decision making. So, nature of the presenting problem. Here's the various levels of complexity in the nature of the presenting problem for the emergency visit level. Level 3s are moderate severity problems. Level 4 are high severity, but they don't pose a potential threat to life or physiologic function. They're high severity, they're higher than the mid-level issue, right? But they're not going to threaten anybody's life. And then finally, the level 5 presenting problem is a problem of high severity that can pose an immediate significant threat to life or physiologic function. Now, this is where we want to talk about differential diagnoses. I want you to see how your documentation will make a difference in how we code a particular chart. Coding isn't just counting the number of tests you do, okay? So here's a 17-month-old brought to the ER by mom, and he has been in his usual state of good health the last 2 days, except he's now in the last couple days had a fever. And as soon as he gets his fever, mom gives him Tylenol and knocks it down, and in 2 to 3 hours it comes right back. Got a little runny nose, no cough, nausea, vomiting, no diarrhea. The appetite's good, no rash. When his fever's down, he's not fussy. Seems a little quieter when his fever is high. Temp right now is only 100.7. So pretty benign right now, but it's, this is a concerning history. Would we all agree? I mean, lots of, okay. Tell me about that. No? What are you thinking about with this kid?
Sounds like he's well hydrated instead of fever, but he's still tolerating feel.
Yep, right. What's the differential? I mean, yeah, I know, it could be a lot of things. But what are the key things that are in your mind in evaluating this child? What do I have to be sure it's not?
It's only 17 months old, it's fever without a source. So you got to look for pneumonia, UTI, meningitis, blah, blah, blah.
Yeah, okay. Pneumonia and meningitis are the two most common that, these kids have as a differential. Now, I'll tell you that in pediatric emergency departments, these patients are always 4s. Always 4s. Because when you talk to a pediatric emergency physician, they look at these kids differently. They say, that's a boiling infection until I'm certain it's not. That is a raging pneumonia until I'm certain it's not. A 17-month-old, they can't tell you what hurts. They're not even sure where or why. There's not enough going on with that kid to be specific, and so we got to really get in there and evaluate them. And they get really, they get really incensed about how important, the differential is just like everything on this kid. Now, talk to a pediatrician about that. This kid's fine. I see these kids all the time. Kids have infections, and you recognize that too. Kids have infections for God knows why, and they go away, and everything's fine, and we never know why, and it doesn't really matter because the kid's always going to be good. So there is a middle ground in here somewhere, but when we look at this patient presenting problem, now the kid who comes in, with a half-day fever. And it never has gotten above. So did we get mom didn't tell us what the fever ran to before she started treating it. But to some extent, it doesn't even matter because low-grade fevers in kids can still be significant disease process. So here we've got to consider a differential that is, all right, let's go through the physical exam and see where the physician is going in the physical exam. All right? So constitutional eyes, ENT, examine the oropharynx, streptococcal pharyngitis, no otitis media, no pharyngitis. small amount of swelling in the retropharynx, but no pus, and no meningismus. So it's pretty clear that the physician had that in mind, right? Because we tested for it. We tested on physical exam. And then we get into the respiratory, and we're getting normal effort, normal breath sounds, lungs are completely clear. So we know that meningitis is in consideration. I think pneumonia is also in play here as a possibility, though it's not described as no pneumonia. You wouldn't do that in a physical exam. But I think this is better described with a course is basically give him some, tolerating his fluids, so give him some Motrin and send him home. I would say that this begs for a differential to say that I really don't think pneumonia or meningitis are in play with this child. Stating that turns this into a 4. And like I said, most pediatric emergency departments, that's how they're going to describe this kid, and that's how they're going to work him up. So then the example here of a 4-year-old with a 2-day cough and fever, given Motrin and a Z-Pak, with no labs and a poorly documented differential, most coding experts would assign this a 3, but documenting a conclusion that pneumonia was not present would have made this a solid 99284, even if you had discussed but ultimately decided against the X-ray. So that child didn't get an X-ray. 42-year-old frequent seizures. Last few months, had his last medication adjustment 3 years ago. He's diabetic, had a 2-minute seizure before presentation, but he's normal now. Process of concluding that all he needs is a med adjustment is actually fairly complex. We have to rule out infection, we've got to rule out trauma, diabetic complications. So what else could be in play here? Now, if you're doing the guy's primary care and you've seen him a couple of times over this last several years, you just haven't gotten to changing his meds, and then he has the diabetic seizure and he's back in your office, you know this guy. So, as a primary care, you're going to give him a little different workup than in the emergency department. Because we don't know this guy, and we're worried about the stuff that could bring him down, where the primary care guy is looking at it as the continuum of, oh, really all I got to do is just adjust his meds and he'll be fine. It's different for you than it is for him. So, physician, the primary care guy might be willing, just by history and physical, to focus principally on the med, but your thought process goes through these other causes, and so a differential would support a higher level of care. So presentations with benign outcomes that commonly report as 3s without labs or studies where differentials can support a 4. Flu. Flu is always, for emergency medicine, it's my opinion, but not just mine, that flus are not flus until you're certain they're not others. It's not something else. So getting there is part of the process of emergency management, making sure that it's not a more concerning cause.
So when you say different, how many are you talking about? So okay, you said flu.
I'm not concerned about how many, I'm concerned about how risky they are.
So okay, we'll use your example of flu. So I'm not going to do anything. Everybody in the family's got the same thing. They didn't get the shots. They I know somebody got tested positive for influenza, and I read on the chart. My differential is influenza versus bacterial pneumonia.
That's all I need.
Blah blah blah.
That's all I need.
That's it.
Yeah. Now on that one, maybe you say it's not an issue. I'm not worrying about him. That's a 2-minute in the door. Get him out. I don't need to see him. I don't need to do anything else. I don't need labs. I don't need an X-ray. I got all I need to know. We'll leave that as a 3. Okay? 54-year-old comes in, not previously exposed, comes in with flu-like symptoms. You going to treat him the same way? Probably not. Right, right. So every patient is different. What I want you to think of is that flu isn't always just flu. That's I mean, when we get there, yeah, flu is flu when we get there. But when it presents, it doesn't always present the same way. That's my point. Okay? Same thing with fevers. Sometimes fevers come and go, and there's benign and then there's suspicious for. And that's what I want you to recognize, that even vertigo, well, we'll see a chart in a minute, but chest pain should be obvious, headaches should be obvious. So here's a 29-year-old intractable cough and sore throat, lasts several days, some body aches and chills. Half pack a day smoker, some past medical, and here in the physical exam, we're documenting a supple neck. What's the point of that? Yeah, right. Did we consider it? Or is that like a throwaway thing? I don't know, I just say it, I'm not even sure why. I don't think that's how it's being used, frankly. I think you document that for a reason. So take what's implicit and make it explicit. That's all I'm suggesting. Chest x-ray, scattered rales with a few expiratory wheezes, no accessory muscle use, no intercostal retractions. Okay, from that, you were able to conclude I don't need an x-ray. Okay, smart doctor, I'll give you that. That's great. Just let me know, that pneumonia was a consideration here. Because if you just leave it up in the physical exam, well, everybody knows that. We need to make clear, we need to make explicit our thought process, how we got to, this is really only bronchitis. Okay? So here's an 18-year-old evaluation of spinning. Her final diagnosis is vertigo. She's had it for the last 5 days. Gets nauseated to the point of vomiting twice. Does have lots of allergies. States she was exposed to mononucleosis, but for whatever that is worth. But here, the HEENT, I might argue that a little more neuro here would be appropriate. About orthostatic signs. The Hall-Pike maneuver is there, but a little more neuro might be appropriate. But the differential on an 18-year-old spinning, okay, that's not a high suspicion for a basilar bleed. I'll grant you, right? But why do we do a neuro on a patient with vertigo? Okay, there we go. So if the patient didn't need the neuro exam, then I get it. Let's take basilar bleed off the differential diagnoses. But if we feel like we ought to do one, there's kind of a reason, right? I'm just making to be sure. Okay, let's make explicit what is implicit. You mean, doctor, you didn't even consider? Well, of course I did. See, I put it up there in the. Oh yeah, but you didn't tell me what you were. Your process. How did you get there? How did you conclude that it's vertigo and not the thing she died of, 5 days later? Extreme case, but terrible thought. Terrible thought. But anyway, see my point about differentials? Just making explicit what is implicit. That's a head injury, thrown off a motorcycle, directly impacting a cement wall 30 minutes prior to the ED arrival. Yeah, okay, some risk associated with that. Guy's cleaning his bike, actually accidentally puts the clutch in gear, goes 6 feet before being launched into the wall. Yeah, he'd be lightheaded and feeling a little dazed. He denied syncope, but admits to being on the verge of losing consciousness. Indicates a mild headache and acute sensitivity to light. So our medical decision making, so there's clearly risk involved here. The medical decision-making, I think the thought process is pretty clear. And the other thing I like about the MDM, we'll talk about this maybe another time, but we build the risk assessment in the HPI that we then manage and draw our conclusions in the MDM. But I think it's always helpful to tie the two together. Start your medical decision making with the concerning thing from the presenting problem. What is it we were worried about? And then we can spell out how we concluded that, the guy's going to be fine. So we did talk about the motorcycle accident. Therefore, we did a CAT scan, performed secondary discomfort and pain, no underlying injury, cervical disease or brain injury was identified, suspected concussion with musculoskeletal injury with a symptomatic relief. So
if you were going to write in their differential diagnosis, specifically spell that out, would you then, would to put it in right before it says therefore CAT scan of both head and neck?
No, I would.
Where would you put it? Does it matter?
No, I don't think it matters where. No, it doesn't. It really doesn't. I just make it part of your flow of your discussion. Yeah, and sometimes it's as much as, I really don't think it is. I don't think there's any bleed here. The CT was pretty clear. So you performed secondary discomfort and pain following injury. There is clearly no underlying injury with fractures, cervical disease, or brain injury identified. So the CT gets me there. I can infer from the CT interpretation that there wasn't a basilar bleed. Okay, that's pretty much what you're telling me. I'm good with that. But it's in the record.
So when we build this out, let's ask the builder, so do you infer then that our differential was subdural, epidural, basilar, cervical spine, all the things? Do you guys infer that? I didn't think so. So they don't infer that. So we don't say it, it's not happening.
Correct. That is my point. They're not allowed to infer it. You have to comment on it. So that's why we're talking about this, because I know they can't code it unless you bring it in. Now they're not going to code the diagnoses, but they're going to consider the risk. Now you all should be able to consider risk from the lab studies. Okay, so like on a CAT scan, on a head injury with a CAT scan, you can infer the risk. You need to know about the mechanism of injury. But that guy who rammed his motorcycle into had a brief loss of consciousness, that is a high suspicion of brain injury. That's why we did the CT. So the risk of brain injury would be what you would choose your level based on. Okay, that's what I'm suggesting, that you can infer that from the lab studies, from the diagnostic workup by the CT or the X-ray. If the X-ray says no pneumonia, you can conclude from that pneumonia was part of the differential. Okay, and then I'll make it a 4 or a 5, depending on whatever else is going on. Okay?
That's my point.
Yeah, okay, good. Okay, some level 4 type patients that make sense and ones that don't. This is a discussion about CPT examples. So I want the coders to recognize that CPT examples are not indicative necessarily of appropriate visit levels. The examples were developed back in the late 80s, frankly, early 90s. Medicine has changed very much, but also those examples were not well defined and they weren't very well tested. They were tested to some extent, but not very well tested to prove as proxies for appropriate visit levels. And the example I want coders to recognize is, in my little worksheet here, the things with the stars next to them are CPT examples. This one, a hip pain, post-fall, suspected broken hip, that right there, that's all that CPT gives as an example. Hip pain, post-fall, suspected broken hip. That is not a good example of a level 4 patient. That is a classic level 5 patient. Patient who's hurt in the nursing home, falls in the nursing home, breaks her hip, and comes into the emergency department. That was given in 1991 as an example of a level 4 patient. It was not then, nor is it today, a good example of a level 4 patient. So you have to use the clinical examples. Well, you have to be careful about the CPT examples. They're often not good examples. Now, the ankle sprain for level 3, that's a good example. Okay, or the level 1 and level 2, most of those level 2s, about the sunburn, there's an example with sunburn for a level 2 emergency. That's a good example. But what you have to do is correspond the risk and the management options and the data discussions that we've had today, and not use the CPT examples as you know, like rock solid, oh, I got a chart that looks just like this, so it must be a level 5, level 4. Because you'll find that the CPT examples for level 5s, subarachnoid bleeds, CVA, acute MI, those are CPT level 5 examples, are all critical cares. Anyway, we do have non-admitted patients. I will tell you probably 75% of your, no, that's not true. You'll have level 5s that are 175% of your admit rate. That's a normal distribution for a Midwest ED. For level 5s, if you've got a 20% admit rate in your emergency department, your normal level 5s would be about 35 to 38%. That's a normal distribution. Because we have lots of patients that come in with high-risk problems that we are able to send home. 25 years ago, many of those patients would have been admitted. We manage differently now. We got better diagnostic tools. We got better ways to handle them, to keep them out of the house. So admit rates from the emergency department have, compared to what we were doing 25, 30 years ago, are lower for the kinds of patients we have to admit now, would always have been admits. A lot of the stuff that we used to admit now gets sent home. So our level 5 rate, again, normally runs about 160 to 175% of your admit rate. That means a lot of discharged patients get coded as level 5s. Does that happen? Yes, it does. So here's an example. An abdominal pain with a CT, labs and multiple reassessments. Okay, we do the CT and it's not a surgical belly. And so the patient's still in pain and we got to work them and manage that pain and get it knocked down with, and try to figure out what's the disease process here. And it could be 5-6 hours of ED stay and they go home with nothing more specific than abdominal pain, unknown etiology. Okay? Has that reduced the complexity because I couldn't come up with it? No. It's actually made it more complex, right? The diagnostic confusion, the diagnostic options for that are dramatic for the number of things that may actually be wrong. So let's recognize that lots of discharged patients end up as level 5s. That's my point there. Critical care, we're going to talk about that next. Just a couple of examples just to show the physicians how we score for this stuff. So take you all the way back to the discussion about HPI. So here's a 16-year-old injures his left ankle. So there's a location statement. While playing basketball, that's a context. States he came down on somebody else's foot after jumping, felt a pop, and immediate pain. Well, there's a timing statement, and had difficulty walking. That's a severity statement as well as a risk of the presenting problem that is of moderate complexity. He has been in good health, there's a past medical, and has no other previous injuries, and there's a system review, an ROS of the musculoskeletal. Going to the physical exam, reveals the left ankle to be diffusely swollen. That's a skin exam. We know that by inspecting the skin. Is ecchymotic, part of the skin exam. Gross deformity and distal neurovascular is intact. So there's a neuro as well as the no gross instability, musculoskeletal. So I have 2 elements of the HPI. I'm sorry, 4. Location, context, timing, and severity. I have a past medical and 1 system review. Right, so if and then 3 physical exams. So let's score the medical decision making. I order the x-ray and complex test interpreted by the physician to be negative for fracture. And then I fit the patient with a posterior ankle splint. That is a risk that is minimal. That is the risk of the procedure. An ankle splint is minimal. I give him some crutches and tell him to be non-weight bearing. That's an indication that the risk of management options is moderate, because I'm going to discharge him. Patients to return to the department after 5 days for removal of splint and further exam. Okay, so if I score the history, I had 4 elements of the HPI, so I got an extended HPI, but only 1 organ in the system review. That's all I needed, right? We only commented about no other injury. So appropriate system review, 1 organ. Keeps it as an expanded problem-focused history. Physical exam was 3 organs. That would be expanded problem-focused. And my medical decision-making, well, I had 1 point there and 2 more there for data. My risk of the presenting problem was moderate. My management options, because I told the patient to go home without additional testing or workup, was also moderate, so they all lined up, medical decision-making all lined up to be moderate complexity. So expanded problem-focused, history and exam, moderate complexity, classic example of a level 3, 99283. Coding options, choose could I have coded for the x-ray, possible procedures. No, I would not have, because the x-ray, I'm sorry, yes, I could have, because the x-ray is described here for 2 components, negative for fracture and positive for soft tissue swelling. So that would be enough documentation that if I was going to bill for the x-ray separately, it would be allowable. The ankle splint is a coding option, but we talk about the patient being fitted, but does not say that the physician did it, and doesn't say whether the physician checked it. To bill for the splint, you either have to put it on yourself or check it after it's been put on for neurovascular status. That wasn't done, so we would not code for the splint, but if we, if the politics were right, we could have coded for the x-ray. Okay, 1 more real quick. Abdominal pain, new non-minor problem. Started 2 days ago, that's duration. Timing persisted. Severity the morning of admission. It's bilateral and lower in the abdominal area. There is some associated sign and symptom here with nausea and vomiting. A GU and a GI are documented, and that through several comments here, we find only a GI and a GU. So we've got 5 elements of the HPI, but only 2 organs in the system review. Physical exam is constitutional. Oops, sorry about that. Physical exam is constitutional with our vital signs. Cardiovascular, unremarkable. Chest exam, musculoskeletal, probably meant to be respiratory, but we don't know. The physician called it a chest exam. GI is a soft abdomen. Some more GI here with the rectal, and a GI with the GU with the pelvic. We ordered labs, so 1 point for all of those labs, 1 more for the ultrasound, and 2 more for having read the ultrasound to show the right-sided ovarian cyst. Bottom line, this patient was abdominal pain secondary to a ruptured ovarian cyst. So while the ovarian cyst was not the concerning issue, there were the risk of the presenting problem of abdominal pain. A high medical decision-making was determined, but the system review only had 2 organs, allowing only a detailed history, and the physical exam had only, I believe, 5 or 6, 1, 2, 3, 4, 5 organs in the physical exam. So while a high medical decision-making would have been allowed, the history and the exam turned that into a 4. Make sense? Okay, questions? I don't need to do any of these other ones, but questions for me?
Kind of a general question.
Yeah, fire. Yep.
Because it's become an issue, we have a freestanding ER where we also see urgent care patients. How does this translate to documenting, because they're coded later, we don't even know if
Yeah,
urgent care
right.
or ER.
Yep. It's all...
I feel like I'm over-documenting for people who should be urgent care and never know if they're being urgent care.
Yeah. Well, that's a good point. Nor should you note it. I mean, it really shouldn't relate. How they're coded will be based on the same principles that I've described. So your documentation should effectively reflect the same attention to the things we're talking about, like differentials, where they're appropriate in the urgent care. You should document them.
Does
Management options, everything.
urgent care building has the same type of stuff where you need so many things?
Yes, it is exactly. Now, their visit levels that they will code for will differ from ours, and the content requirements will differ. So they may choose a different level than we would in the ED. So how they get to those levels, the coding algorithms are different. But how they decide, is it an extended, or is it a detailed, or is it an expanded problem focus, those are all the same. All the same. Yep, so they'll be looking at the same content we look at. They'll just be making different choices. Other questions?